much, and let me move on to the next talk, which is around atypical mycobacteria. I hope good. So the objective of this talk will be to share with you our experience with atypical mycobacteria and nocardia, the two acid-fast bacilli that we have seen as causative organism for microbial keratitis, and to give you a perspective of clinical scenario in which you must suspect atypical mycobacteria as causative agent. And I'll begin with this case, and this is my first case of atypical mycobacteria that I saw when I was doing fellowship. So I keep showing this because this was true teacher for me. Was a 25-year-old male who came to us with the history of pain, redness, watering of 6 weeks duration following a corneal foreign body removal. The patient was initially treated with antibiotic by the local physician, showed some response but then deteriorated, and finally after changing antibiotic for 2-3 times, this patient was referred to us. We did corneal scraping and could not identify any organism both on the smear and culture. So we treated at that point of time with ciprofloxacin monotherapy because that was the most common way corneal infections were being treated. Patient showed some response. You can see some scarring, but then I saw in 4 weeks later there was renewed activity at the central edge of the infiltrate. We switched antibiotic to cefazolin and tobramycin. Patient showed some response further, and then this lesion again reappeared, and that made us nervous as to what is happening. Why is this patient not responding to treatment? We reviewed the clinical history and found why was this patient presented to us with 6 weeks history, but still you see the infiltrate is very small. It's a slowly progressive keratitis, unlike many other virulent organisms that cause very active. And then there was a definitive history of foreign body removal. And we went back, reviewed the literature, and found that this is a typical scenario in which acid-fast bacilli are the causative organism. We also saw that there was a waxing and waning course. Patient showed some response, deteriorated, showed some response, deteriorated. We reviewed the corneal scraping and found multiple unstained bacilli. We counter-stained with Ziehl-Neelsen staining and found multiple acid-fast bacilli, and that was published in the journal Cornea at that point of time. Fortunately, we had a confluent growth on blood agar, which was identified as Mycobacterium shilloni. So atypical mycobacteria pose several diagnostic challenges because the clinical picture is not very characteristic. They can present as suppurative keratitis, which is localized, diffuse. They may even appear as a graft infiltrate. So it's very varied clinical picture. Plus, we are not much familiar. That's not the first diagnosis we think about whenever we deal with the keratitis cases. And then if you do not use a specific stain, it goes unnoticed because of they are very resistant to staining by the typical gram stain. So they are missed often even in the microbiology. So what we did is that we analyzed up 52 cases of atypical mycobacteria in the year 2016 and found that few characteristic feature of atypical mycobacterial keratitis. The history duration is usually in weeks to months. Many of these patients will come to tertiary center with a very, very long history. Number 2, the trauma was the most important predisposing factor, whether it be surgical trauma, which is post-keratoplasty, post-scleral buccal, or post-foreign body removal, or even the metallic foreign bodies. In addition, among the surgical procedure, we found that atypical mycobacteria was seen following cataract surgery, LASIK, keratoplasty, and scleral buccal infection. We also found that many of these patients have a history of not only treatment with antibiotic, but they were given corticosteroid in somewhere during the course of treatment. And the microbiology typically misses these organisms on gram stain unless your microbiologist is tuned to identify these cases. The antibiotic susceptibility was highest for azithromycin and clarithromycin, followed by amikacin. Now, when you treat these infections with amikacin, you will find that they develop some side effects of aminoglycoside toxicity in the form of pseudomembranous conjunctivitis. Another challenge with this infection is that they very slowly respond to therapy and at times require some kind of debulking before they get cured, and therefore we should not hesitate to not undertake them for surgical procedure if it is required. To give you perspective under what circumstances we should suspect atypical mycobacteria, let me take you through this case of 29-year-old male who presented with the history of 1 month duration. There was no history of trauma, no similar episodes in past, no systemic illness, and the clinical picture was a case of stromal keratitis. And most likely diagnosis under this circumstance will be HSV stromal keratitis. When we looked at the medical history, we found the patient was treated with cefazolin, gentamicin every 1 hourly, and despite that, this patient was not responding to medical treatment. So we thought that we are dealing with a case of HSV stromal keratitis and started treatment with prednisolone and oral acyclovir. The patient showed some response. You can see that edema has reduced. You are able to see iris details better. And finally, in about a month time, the edema has almost disappeared. What is your impression? What are we dealing with? Are we right in the treatment that we are offering, or there are any concerns? And I think if you pay attention to this lesion, a very small lesion here became worse and now has completely as if chalky white deposits are present. That made us suspect that we are dealing with something which is not letting this epithelial defect heal. We did corneal scraping and found multiple acid-fast bacilli. So in your clinical practice, anytime you find a patient which is presenting with the history, which is long-standing in weeks and months, where the patient is showing waxing and waning course, if there is a history of trauma or metallic foreign body, it's substantiate, and especially if there has been surgery. And if the patient has been treated with steroid, inflammation subsided, then again, you should suspect atypical mycobacteria. This is yet another patient, was treated as HSV geographical ulcer. We found that this patient showed no organism on the initial corneal scraping. With 5 months history, we suspected strongly atypical mycobacteria and gave a drug holiday to pick up the organism. And slowly, over a period of time, this patient responded very well and got cured on amikacin therapy. Coming to nocardia, this is being an organism which is filamentous acid-fast bacilli isolated from infection everywhere in the eye. Here again, the mean duration of history is usually long, and they present with the classical pinhead-sized lesions arranged in a wreath pattern. But you should also note that at times the clinical picture may resemble fungal keratitis or any suppurative keratitis. Fortunately, the diagnosis is relatively easy because it stains well even with the gram stain or 1% acid fast and grows as a chalky white colonies on chocolate agar. So you are unlikely to miss this organism. And this organism also is very susceptible to amikacin, gentamicin, and other aminoglycoside. and the average duration of treatment in these patients is 6 to 8 weeks and respond very well. Only few cases require surgical management. We published a complete review of nocardia keratitis in ophthalmology way back in 2012, and you can refer that as a reference for knowing more about nocardia, not just keratitis, but also scleritis as well as endophthalmitis. To summarize, non-tubercular mycobacteria are rare but important causes of keratitis. They have variable clinical picture, but accidental or surgical trauma with the waxing waning course and a localized infiltrate should give you a high index of suspicion, which will help you establish the diagnosis. Thank you very much for your kind attention, and I'll be happy to take any questions on this.